Good morning all. My paper is on functional outcome in patients undergoing orbitotomy for orbital cavernous venous malformation. No financial interest. As we know, cavernous hemangioma is a simple venous malformation seen in middle-aged females. Excision biopsy remains the treatment of choice. However, visual impairment has been reported in 2 to 24% of cases. So in this context, we did a study to analyze the functional outcome in patients undergoing orbitotomy for intracorneal cavernous venous malformation. It was a retrospective interventional study of 8 years in a tertiary care center in South India. Detailed history, ophthalmic evaluation, orbital imaging, and tumor volume was calculated in all the cases. Surgical approach was determined based on the location. Lateral orbitotomy with or without osteotomy was done using stellarite incision or Berkey's incision. Cryo-assisted tumor removal was done in all the cases. Muscle disinsertion and reinsertion was done accordingly, and pupil was monitored throughout the surgery. Those with 6 months follow-up were included, and those referred for revision surgery as well as in the extracorneal location were excluded. Patient was admitted for 1 day and discharged next day and followed up at 1 week, 1 month, 6 months, and yearly thereafter. Refraction was done at follow-up visits. Color vision and visual field and OCT was done if there is subnormal vision. The main outcome measures were changes in visual acuity and refractive error, ophthalmoscopic changes, and complications related to surgery. We had 10 eyes of 10 patients with a mean age group of 44 years with a mean follow-up of 21.8 months. Females outnumbered males in our study. Proptosis was the most common presenting symptom. Color vision was normal in all patients pre and post-operatively. Visual fields was also normal. One patient had central scotoma. Coming to the ophthalmoscopic findings, hyperemic disc and disc edema was present in 2. Both were resolved in the postoperative final visit. Chororetinal folds were present in 4, it persisted. Serous macular detachment present in 1, it persisted. Visual acuity was less than 6/18 or equal to 6/18 in 1, and it has improved in the postoperative period. All other patients had good vision pre and post-op. Coming to the changes in hypermetropia, hypermetropia was present in 70% of cases with a range of plus 0.5 diopters to 5 diopters, of which 4 eyes had more than or equal to 2 diopters. In the postoperative period, 5 had persistent hypermetropia, and there is an average reduction of 33.6% reduction. Coming to the radiological features, the maximum horizontal dimension ranged from 1.4 to 2.9 millimeters, and the tumor volume ranged from 2.1 to 7.6. Infralateral was the most common location. Lateral orbitotomy alone was done in 7 cases, and lid split was in 1. In 2 patients, we combined both lateral orbitotomy with lid split, and medial rectus was disinserted in 1 patient to facilitate tumor removal. Coming to the complications, tonic pupil was present in 1 and late ophthalmos was present in 1. This is my second case. She was a 45 years hypothyroid, pre-op hypermetropia, intracorneal mass, underwent disc edema, complete excision, follow-up at 1 month. So coming to discussion, this is a unique study of 10 patients where dual approach has been used in 2 cases, and none of them had any loss of vision. Coming to the visual impairment following excision of cavernous hemangiomas, there is a reduction in best corrected visual acuity reported in 3 to 32% of cases, and no light perception has been reported in 1.2 to 4.2% of cases. Can occur due to posterior optic nerve ischemia or CRA or due to traction or manipulation of orbital tissues. However, in our series, all had good preoperative and post-op vision. Dual approach we have used in at-risk patients, and muscle was disinserted. We had 33.6% reduction in hypermetropia. As per Harris et al., he noticed 75% of preoperative hypermetropia was retained in spite of complete tumor removal. Scleral fibrosis and remodeling with a chronic distortion can lead to permanent scleral deformation and permanent change in axial length. Choroidal folds was present in 40% of cases, and all the folds, even though reduced in height but persisted even after complete tumor removal. The reported incidence is 14% to 41%. In our series, only intracorneal masses we have taken, and the long-standing choroidal folds can lead to RP hypertrophy and atrophy. One had tonic pupil. It occurs due to injury to short ciliary nerve or ciliary ganglion. It's a small sample size limitation. So what this study adds is a functional outcome following orbitotomy for intracorneal cavernous venous malformation remains excellent with careful surgical technique, proper selection of surgical procedure, and careful intraoperative dissection. 2 surgical approaches can be combined in at-risk tumors. Post-op recovery depends on the preoperative findings. Smaller tumors, small refractive errors, favorable parameters. Long-standing larger tumors with globe indentation can lead to persistent choroidal folds. So we propose early surgical intervention in symptomatic intracorneal cavernous venous malformation, and persistence of choroidal folds in the postoperative field needs further research. These are my references. Thank you.
Thank you, Dr. Marian, for the excellent presentation. Do you have any questions for her?
Is there any role of intervention radiology in these cases?
Yeah, we can if you're suspecting one intracornal other arterial malformations. But here, all patients preoperatively itself, the diagnosis was quite evident.
Marian, can you tell us a little more about that patient where you combined a lateral orbitotomy with a lid split? So where was the tumor? And
It was deep apical and intracornal, apical intracornal. So when I was removing the tumor, that pupil was dilating. So I was literally scared whether the patient will get central retinal artery occlusion because of the pressure. So I just split the lid so that the tumor removal was easy, so that safe, yeah, for the safety.
Have you done an analysis of the radiological appearance of the tumor before surgery? Because like you know, there are two types of tumors, the pear-shaped hemangiomas and the circular ones.
Yeah.
The circular ones usually have excellent prognosis. It's only the pear-shaped hemangiomas which go right to the apex, no, which are very dangerous.
Yeah.
Have you, in your study, has any patient
I had two cases. For both, I had did the dual approach. While I was removing the tumor, the pupil started dilating, so I was literally
dual approach of lateral orbitotomy with
lid split. So when the moment I split the lid, the orbit was completely open. Otherwise, when I do the traction on the lateral wall, the lid is getting stretched and pressing on the globe. Tumor is also pressing on the globe. So I don't want any CRA.
In your conclusion, you had concluded that early surgery is indicated for symptomatic. What do you mean by symptomatic? What will be the
proptosis, then with hypermetropia and disc edema? I mean, what are the signs? Usually patient presents asymptomatic, we can find out proptosis, do imaging. So when the vision is normal, fields normal, pupil normal, sometimes when we tell the patient you can wait for either 6 months or 10 months or you come for yearly follow-up with MRI. In that case, I think we can intervene early.
So a patient with mild proptosis with excellent vision and no symptoms at all.
If the patient is willing, I will advise.
It's an indication for us to counsel the patient for early
surgery. Because I had one patient where the serous macular detachment persisted. He was keeping the tumor for at least 5 years. So everybody was telling the same. If you remove the tumor, your vision will go. But then I told, I also actually assured the patient your vision will improve after the surgery. But his vision pre-operated, it was 6/18, improved to 6/12 in the post-op. The serous macular detachment and choroidal folds was persisting. He had a very large tumor. He was the biggest biggest one in my series.
Because usually the choroidal folds usually does not have significant visual
immediately no, but long standing they can have RP atrophy and all.
Thank you.
Yeah.
Thank you.